Hi guys, good evening, good evening, good evening. I'm Dr. Sandeep, your surgery guy, and we are going to have a discussion on the PYQs, right? So our objective is to target on the NEET PG 2024. I will take up all the PYQs which were there in last 5 years and we'll try to give in a comprehensive way. ठीक है? So objective ये है कि question उसका जो topic है and what are the variables that we can get, ये चीजें हम डिस्कस करेंगे. अलॉन्ग विद दैट व्हेन आई डिस्कस दी ऑप्शंस हम ये भी देखेंगे कि कौन सा ऑप्शन करेक्ट है, कौन सा गलत है. विल ऑल्सो ट्राई टू एनालाइज दैट हाउ वेल कैन वी eliminate the other options that we have, and then from thereafter we'll be able to have a better choices. Okay, so without wasting any further time, let's kickstart this session. So we'll be taking up the question number 1 again. This is a repeat question. You have been seeing this question from a while, but again, I don't know why some of us still continue to hamper. We'll try to make some sense into it. Okay. Now, the question says a patient underwent a surgery of breast cancer, right? She now presents with painless swelling involving the arms as shown in the image below. What is the likely diagnosis, right? Now, it is a case of post-operative. So, for breast cancer, what surgery do you think the patient would have undergone? Let's say the patient has undergone a modified radical mastectomy, right? Now, when we talk about MRM, you need to understand that what are the possible complications that we are going to look across, right? So, we talk about the post-operative complications. So, when I talk about the post-operative complications, which are associated with modified radical mastectomy. Now, the easiest way to understand that you can split this post-operative complications into number 1, immediate post-operative complications. We have the immediate post-operative complications and a delayed post-operative complications. For our immediate post-operative complications, you can remember a small mnemonic to memorize the complication that you will see, that is called as SWAP, right? Now, what does SWAP stands for? S stands for seroma formation. In fact, seroma is the most common complication associated with the modified radical mastectomy. Along with seroma, W stands for winging of scapula. We all know it. The winging of scapula is due to the damage of the long thoracic nerve. A stands for arm edema, that is your upper limb edema. It's an expected complication. And B stands for black. Black indicates flap necrosis. It indicates flap necrosis. So, seroma, winging of scapula, arm edema, black, that is flap necrosis, are the common immediate, or I guess immediate post-operative complication. When I say immediate, it is within the first month of the surgery. Now, when you talk about the delayed post-operative complications, the one that it is going to stand out as a delayed post-operative complication, it is going to be your Stewart-Travis syndrome. It is your Stewart-Travis syndrome. Now, what is a Stewart-Travis syndrome is? In a Stewart-Travis syndrome, it usually occurs when a patient has underwent a modified radical mastectomy. It will take approximately, this complication would take at least 5 to 10 years. So, after 5 to 10 years of modified radical mastectomy, patient is now going to present to you with lymphangiosarcoma of upper limb. Now, this lymphangiosarcoma of the upper limb is what we call it as the Stewart-Travis syndrome. Now, you will see the differentiation is very much evident on the image. I'll show you how does a Stewart-Travis syndrome would look like, because when you look at the arm edema, it is general edema that you see here. But when you look at the lymphangiosarcoma, you see this bluish discoloration with involvement of skin, and all that area around it tells you that it is lymphangiosarcoma of the upper limb. Now, if they ask you what is the management that you're thinking about the lymphangiosarcoma, remember, prognosis is really bad, but when you talk about management, it is going to be your 4-quarter amputation. It is your 4-quarter amputation. Now, in the 4-quarter amputation, the structures that I'm going to remove I'm going to remove the entire arm. I'm going to remove the clavicle of the same side and the scapula of the same side. And the scapula of the same side, and these are the structures that you're going to remove in a 4-quarter amputation. Now, this particular slide of the post-operative complication of modified radical mastectomy is very, very important. If they want to ask you further, this is your Stewart-Travis syndrome, or what we call it as the lymphangiosarcoma. This is the lymphangiosarcoma. This is the lymphangiosarcoma, right? Now, if they ask you what are structures preserved in modified radical mastectomy, that is also an important question. So, quickly, structures preserved in modified radical mastectomy. Now, the structures that are preserved in modified radical mastectomy can be remembered by a small mnemonic, that is your ABCD. Now, A stands for axillary vein, B stands for the Bell's nerve, that is a long thoracic nerve, C stands for the cephalic vein, and D stands for nerve to latissimus dorsi. It is the nerve to latissimus dorsi. The first three are absolutely important and the rest can be taken care of, right? So, structures preserved in modified radical mastectomy are the axillary vein, the Bell's nerve, the cephalic vein, and the nerve to latissimus dorsi. So, coming to our question. Now, in our question, what is your diagnosis? It is not a lymphangiosarcoma, it is not a venous thrombosis, it is not a cellulitis, it is going to be lymphedema. It's a post-operative lymphedema that you're looking at. So, the answer to this question, that is question number 1, is going to be A for Ahmedabad, right? So, that's your answer. It's a post-operative lymphedema because of axillary dissection. Now, when you talk about lymphedemas, couple of important tables that you need to know. The table number 1 is the differentiation of the causes of primary and the secondary lymphedemas. I have given you, remember, if it's a congenital, that is age less than 2 years of onset, it is going to be sporadic or familial. Familial is called as the Milroy's disease. Then you have precox, which is between 2 to 35. Familial precox is what we call it as the Meigs disease, and tarda, which is going to be after the age of 35. So, these are the causes of primary lymphedema. Secondary lymphedema, remember, the most common cause is going to be your parasitic, that is your filariasis. Other than that, you have fungal, exposure to foreign body, primary lymphatic malignancies, metastatic spread to nodes, radiotherapy nodes, surgical excision to the lymph nodes. This happens to be the most common cause of upper limb edema, especially in breast cancers, right? So, surgical excision of lymph nodes. Now, two important things. Overall, most common secondary cause is going to be your filariasis, but if they specifically ask for upper limb, the answer is going to be surgical excision. Apart from that, trauma, superficial thrombophlebitis, DVT are the other causes. Now, the grades of lymphedema is also your important exam question. Remember, the grades is given by your Brunner's classification. I have given you the Brunner's. They are subclinical or latent. We call it as grade 1, grade 2 and grade 3. I have given you the whole component, but if you want to really simplify this, the grades is depending upon, it is the status of the edema. It is the status of the edema, change on elevating the limb, change on elevating limb, and is there any secondary changes? Is there any secondary changes to the limb? So, we have grade 0, which is called as latent. There is no edema, there is nothing that happens on elevating the skin or the elevating the limb, and there are no secondary changes. So, this is basically an interstitial component. It is still started to develop, not yet developed. But grade 1, there is presence of edema. When you elevate the limb, swelling completely disappears. Swelling completely disappears. It completely disappears. There are no secondary changes. Grade 2, you see the edema will become a bit more progressive. Here the swelling reduces but does not disappear. Swelling reduces on elevating the limb. There are no secondary changes. Grade 3 is the most extensive, where the edema is persistent. the limb remains unchanged on elevating, and this will also have associated secondary changes like excoriation. There will be papillomas, there are papillae, there will be discharge. All that will be there, and that is a grade 3. Again, this is an expected exam question. They have only asked you the name, that is the Brunner's classification, but again, because it is not an extensive classification, expect a question for the exam as well, right? So these are the various components of the Brunner's. This is the easy version of Brunner's. Okay? So this is all in all that you should know with respect to the Brunner's classification or with respect to that of lymphedema. Then you have what are the malignancies which are associated with lymphedema. Again, a tricky question, but again easy or remember in terms of handy. We just discussed lymphangiosarcoma. The lymphangiosarcoma happens to be the Stewart-Travis syndrome. We just spoke about it. Then you have the Kaposi sarcoma because of HIV virus, squamous cell carcinoma, liposarcomas, malignant melanomas, malignant fibrotic histiocytomas, BCC, that is basal cell carcinoma, and lymphomas are the malignancies that mimic as lymphedema. Okay? These are the malignancies which limp as lymphedema. Guys, somebody is asking, is this session helpful for FMG exam which is going to come? Beta, NEET PG and FMG exams are almost at the same level. Okay? So stop thinking about it कि यार FMG is going to be an easier exam and NEET is going to be a difficult exam. It is not. Both of them are going to be at the same state level. Certain things we might add up a bit if you are an FMG student. Otherwise, it is going to be absolutely fine. Oh, hi Adya. Oh, you are also online. Thank you for watching. You're too early, to start surgery. Right? Take some time. So as I was saying, so this is not to differentiate. See, every single topic that we're going to deal is an important topic, whether it is a NEET or an FMG component. Okay? So keep that into the consideration and let's move on. So the question number 1, see, the question number 1 was a very easy question. But you always make a mistake because of lymphangiosarcoma. You think it is lymphangiosarcoma because that's how they're supposed to ask, but they don't ask what you think they'll ask. They'll only ask what they want to. So answer the question to what they're asking for, not what you know. That's an important component to be remembered. Okay? Chal. Now, again, a lot of times students have been asking me, sir, how to differentiate between a DVT and a cellulitis. We're talking about the DVT of the lower limb. We're talking about the DVT of the lower limb and the cellulitis of the lower limb. Right. Now, when you talk about DVT in terms of presentation, it's slightly difficult for you to just analyze and say what is the difference. But if you talk about it, DVT, you will see there is sudden severe onset of pain. There is sudden severe onset of pain. Cellulitis will have a gradual increase in pain. There will be gradual increase in pain. DVT, you will see associated calf pain alone, but cellulitis will have a diffuse pain. This will have diffuse pain. DVT will have low grade fever. Cellulitis patient is usually associated with high grade fever. There will be high grade fever. Here the patient will present to you or the swelling will have edema, but remember it is initially pitting. It is initially a pitting edema, but eventually, or I can say in a late stage, it becomes non-pitting. In a late stage, it becomes non-pitting. Cellulitis will also present to you with edema, but this time it will be only pitting edema. This will only have a pitting edema, right? Now, DVT on the other hand, the component of pain increases on passive flexion, of toes or squeezing cuff. Here pain remains same irrespective of position. It is irrespective of position. There will be no erythema. Erythema is usually absent in DVT. You will see presence of erythema in cellulitis. Usually DVT skin won't have any discharge, but cellulitis can have an infective foci which can present to you with discharge. Right? So these are the helpful differences between the DVT and the cellulitis. It is the cellulitis. Okay? So these are the important differences that you need to know. So we covered all the options that were there. So let's dig into the next question. I hope if you have any questions, feel free to ask in between also. Advice for NEET PG, beta, advice is very simple. Read, revise, repeat. Read, revise, repeat. That's it. As we made a small video of the strategy also. I hope that was also useful. But those who have not looked at the strategy video, the component is very simple. You require 5 revisions. You need to do 5 years of your PYQs that we are trying to do it today. And you need to remain focused, stick to the same source, do not change, give GTs, give questions, start doing as many, but now you have that slot wala part also, right? So now a lot of students who have messaged me, I told them it's a very simple thing. Don't look at the change in the exam pattern, nothing. It's the same questions that you're gonna appear to. The only thing is now they're giving you a slotting. So all that you have to do is, now it's easier for you to concentrate, right? 40 minutes ka concentration hai, then you can break your concentration, rebuild it back. Pehle kya tha 3 ghante, right? You have to put it like this. Now it is a 40-minute slot. So all that you have to do is take a clock, put 40 minutes, put 40 questions, start doing it, right? So you will need to understand that how it is going to move across, right? So that 40-minute slots helps really, really well. Okay? Start preparing for that as well. Hi Adya, hi Adya, how are you? I found your hi right now. Is this PDF available for everyone? Beta, this is available for every student who is appearing for NEET. Right? You can get the PDF directly from the PW Mededs Telegram channel, or you can directly DM me on the Instagram. I will send you the PDF on the Insta as well. So don't worry about this. This is my Telegram group also. Everywhere, wherever you want, we will give you this PDF. So don't worry about it. Okay? So let's concentrate on the component that we're looking. See, each and every table that we have put across now, it's like a mind map. So when you start analyzing a question, the question looks very simple. Post-operative complication of MRM, कोई भी बता देगा ऐसे टक 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 करके, right? But point वो नहीं है. Point है कि बाकी 3 options का क्या relevance है. So we try to understand the complications of MRM. We try to differentiate between lymphangiosarcoma and normal lymphademas. Then we spoke about lymphademas in general. Then we spoke about what are the malignancies that mimic as lymphademas to cover up the differential diagnosis. Then we looked at DVT and cellulitis, जो बहुत commonly अगर internship अगर अपने ना शिद्दत से की होगी ना, तो ये challenge बहुत बार आया होगा कि यार DVT है कि cellulitis, especially if it is in the lower limb. ठीक है? So in that context, make sure that you're using this resource pretty well. Now, let's move on to the question number 2. Now, the question number 2, it says, which of the following statement is true regarding the condition given below? Right? Now, if you look at the condition given below, it looks like a Fournier's gangrene which is completely been disintegrated. So if you look up this context, so involvement of perineum and the abdominal wall. If only the abdominal wall downwards, it can be a Melanese ulcer. If it is only involving perineum and then going into the abdomen, it could be a Fournier's also. Now, how do you differentiate? So it always comes across ki whether it is involving only the post-operative abdominal wall synergistic gangrene or it is a perineal synergistic gangrene. Either ways, both of them are a combination of both aerobic and anaerobic infection. So let's look at the options that we have. We're looking for true, right? Now, patients must be started on anti-gas gangrene serum therapy, not necessary. Mixed floral aerobic and anaerobic respiration is correct. Bilateral orchidectomy generally performed. See, if it's a Melanese ulcer, and that Melanese ulcer is a synergistic gangrene of the abdominal wall that involves scrotum and testes, then you have to do an orchidectomy. Otherwise, it is not necessary. Now, compulsory urinary diversion is performed. No, it is only performed until, see, you need to understand if the urethra is getting involved. That is only when the urinary diversions are to be done. Otherwise, you can put a Foley's catheter and be done with it. So answer here is going to be B for Bombay. Now you can see this is how the Melanese ulcer would look like, right? So when you look at the Melanese ulcer, this is the abdominal wall. It is completely put across here, right? You can see there is an abdominal wall synergistic gangrene. It is usually caused by Staph aureus or the Staphylococcus organism, and that is your exam question. So Melanese is caused by, it is either caused by the Staph aureus or the Streptococcus. Okay? So question number 3. Something got stuck. 1 second. Okay, so let's go to the question. Next one. So baby is playing unsupervised. You should not leave babies play unsupervised. Was brought with the complaints of difficulty in swallowing for the last few hours. It is swallowing, not breathing. It itself gives you a diagnosis here across, right? The X-ray image is given below. What is the diagnosis? Because he's having difficulty in swallowing, I'm thinking the foreign body is in the esophagus. So look for the option. Where do you have? Is the foreign body in the trachea? No. Is it in the esophagus? Yes. Is it an artifact? No. Soft tissue calcification? Like, no. Right? Now, how do you know that is this foreign body is in the esophagus or it is in the trachea based upon the radiograph? Now, you see in the trachea, you will have sagittal. You will have the orientation of the coin as sagittal, but esophagus, it is N face, right? Esophagus, we call it as the N face presentation. N face का मतलब है पूरा face of the coin you will be able to see like this, right? Whereas here you can only see a sagittal section of the coin. So it is what we call it as the sagittal view, right? So if the, usually if I say what is the most common site for dislodgement, it is going to be the right main bronchus. Here it is the right main bronchus. If they ask you in the esophagus, the most common site, it is going to be your cricopharynx. It is going to be your cricopharynx, right? So that is how you are going to differentiate. हाँ, AP में shape जो होगा, अगर वो circular है, that is going to be esophagus. Agar if it is going to be a little bit obliquely placed or sagittally placed, then it is in trachea. Simple सा component है. लेकिन इससे interesting ये है that how do you differentiate whether you have coin or a button battery? यही सबसे important component है कि differentiate कैसे करोगे कि यार coin देख रहे हो या button battery देख रहे हो. So that is where it comes handy here. Now, if you see at this particular image, right, you can see there are rim that is present, right? So, एक rim बाहर की तरफ है, there is an outer rim, and there's one more rim which is inside. So, if there is a rim sign present, if the rim sign is present, then it is a button battery. Then it is a battery. If there is no rim sign, so you can see it is only a uniform component. There is no rimming, there is no, there are two components here. So if the rim is absent, then it is a coin. Now why it is important is battery is emergency. Battery is emergency. Coin, if it is in esophagus, you can wait and watch. If it is in trachea, then you have to remove it. What is the best modality to remove? It is going to be rigid bronchoscopy. Okay? Now, why it is an emergency in battery? Because batteries are going to spill alkali. And alkalis are associated with liquefactive necrosis, this is going to cause an extensive damage to that of esophagus, so or the stomach wherever it is dislodging, hence it has to be removed at the earliest. ठीक है, तो यही क्वेश्चन है फॉरेन बॉडी में जो आपसे पूछेंगे कि भाई कहाँ पे आके क्या फंसेगा, एंड दैट इज व्हाट यू हैव टू बी प्रिपेयर्ड एंड बी रेडी अबाउट. ठीक है. Now, there are certain spotters in esophagus that they are going to ask you over and again. A quick component which is going to be here. Spotter number 1, any idea? Spotter number 1, kya hai? You can see a massive air bubble in the thoracic cavity. You see the mediastinum is being shifted and it looks like an X-ray of a baby. So this is going to be your congenital diaphragmatic hernia. This is the Bosch-Dallek hernia. Now, in the Bosch-Dallek hernia, you see there is massive air bubble in the thoracic cavity. Massive air bubble in thoracic cavity. There is a massive air bubble in thoracic cavity. There is presence of shift of the mediastinum, and that shift is what we call it as dextrocardia. That shift is what we call it as the dextrocardia, right? So there is air bubble and dextrocardia. In fact, when you say what is the triad of Bosch-Dallek hernia, the triad of Bosch-Dallek hernia is RDS, right? R stands for because the lung is being compromised, there will be presence of respiratory distress. D stands for radiologically, you will see presence of dextrocardia. And S stands for scaphoid abdomen. It stands for the scaphoid abdomen, right? It stands for the scaphoid abdomen. Okay. So that's your first spotter that you would see. Now, what is the spotter number 2? Any idea? Anybody wants to comment? Nicely, you can see barium swallow is there, and there is a pouch that is collecting it, and that is going to be your Zenker's diverticulum. It is your Zenker's diverticulum. Now, how do you know it is Zenker's? You can see it is present in the cervical region. As you can see, this is the base of the skull and this is your cervical vertebra. So, because it is a cervical diverticulum, Zenker's is an example of cervical diverticulum. Zenker's is an example of a false diverticulum. This is an example of a false diverticulum. This usually exists most commonly on the left side. It is a left-sided posterior diverticulum. This is a left-sided posterior diverticulum. And remember, if the size is greater than 3 centimeters, then you have to perform the Dolman's surgery, right? So I've given you all the important points that you need to know in the context of Zenker's diverticulum. Now, when you look at the image number 3, again a very characteristic image of the esophagus. So this is what we call it as the apple core sign, and this apple core sign is usually seen in esophageal cancer. Now, what is more important than the apple core sign? As you can see, this is, if I draw the apple as if somebody has eaten the core and left behind, that's how the apple core sign looks like. But more importantly, if I point out at a component here, you can appreciate the one that I'm drawing in a different color. What is this? You see that nice hunch that is being formed, right? ये जो hunch बना हुआ है, ये hunch क्या है? This is very important, and this is what we call it as the shouldering sign. This is what we call it as the shouldering sign, and shouldering sign basically tells you about malignancies. Okay? So shouldering sign is very, very important. Now, when you look at the spotter number 4, the spotter number 4, you can see there is a uniform mucosal rim has been formed. So we call it as the symmetrical mucosal ring in esophagus. Now, because you know it is closer to the gastroesophageal junction, how do you know? This is because I can spot the diaphragm, right? So this is usually a complication of GRD, and this is what we call it as the Schatzki's ring. This is what we call it as the Schatzki's ring. right? It's a mucosal ring that you have. But at the same time, you see the spotter number 5, you see the same mucosal ring is present on the upper part in the cervical esophagus, and this is what we call it as the upper esophageal web. Now, whenever there is an upper esophageal web, the one thing that you should not forget that it can be associated with Plummer-Vinson syndrome. It can be associated with a condition that is called as the Plummer-Vinson syndrome. It can be associated with the Plummer-Vinson syndrome, which is also commonly referred to as the Patterson-Kelly syndrome. Also commonly referred to as the Patterson-Kelly syndrome, right? So, what are the components of Patterson-Kelly syndrome? Number 1, there will be presence of iron deficiency anemia. There is atrophic glossitis. There is atrophic glossitis. Presence of upper esophageal web. There is presence of upper esophageal web. There is visceromegaly. There is visceromegaly and koinonia, right? So, these are the components that you will see in the Plummer-Vinson syndrome. Okay. But Zenker's, Schatzky's, I'm not able to understand. Shoulder, what is your question? Schatzky's ring or Zenker's में difference क्या है? But Schatzky's ring is a mucosal component, right? You see there is notching, there is inward notching. Zenker's is an outpouching. Okay. चलो. Now, spotter number 6, again an important exam spotter. Can you see what is this spotter number 6? Spotter number 6. Now you see there is something which is coiling inside, right? There is a coiling of nasogastric tube, and this coiling of the nasogastric tube indicates tracheoesophageal fistula. Remember, here you see presence of coiling of nasogastric tube, right? Now, one controversy is what is the investigation of choice. There is no controversy, there is slightly misunderstanding. So, the investigation of choice is your contrast imaging. So, you do put a contrast in the baby and then take an image, that is basically an X-ray, and remember the safest contrast. The safest contrast is going to be iohexol that you will be using for mapping the tracheoesophageal fistula. Okay? So, that is what they are going to ask you. So, these were your radiological spotters. One more spotter that is expected from an upper GI endoscopy. This is an upper GI endoscopy. What do you see? You see there is a normal pink mucosa, and then you have inner red velvety mucosa. You have an inner red velvety mucosa, and needless to tell you, this is going to be what? Your Barrett's esophagus. Now, if they ask you, what is the reason for Barrett's esophagus? The answer is going to be long-standing untreated GERD. All these are important exam spotters. This single slide itself is gold mine for you. Okay? So, don't forget to review these particular slide. Very, very important. Okay? Now, moving on to the next question. Now, I have a 75-year-old man with a prostate cancer presented to you with a PSA of 9 nanograms per ml. Now, is PSA high or low? For that, you need to understand what is the normal prostate specific antigen. Remember, the normal PSA is less than 4 nanograms per deciliter. Now, if you have a patient with prostate cancer, it is usually more than 20 nanograms per deciliter. If it is a metastatic, prostate cancer, then it is going to be more than 35 nanograms per deciliter. It is more than 35 nanograms per deciliter. Now, sometimes you can have a PSA which is not as high as 20, but then it might be elevated enough, right? So, if you have a PSA value if you have a PSA value which is more than 5, we call it as elevated PSA. Now, elevated PSA is PSA which is more than 4 nanograms per deciliter, but it is less than 20 nanograms per deciliter. So, we need to know that what are the conditions that can cause an elevated PSA levels, right? Conditions that are associated with elevated PSA levels can be remembered as A, B, C, D. A stands for patient having an acute bacterial prostatitis. B stands for if you have done a prostatic biopsy or if a patient is having benign prostatic hyperplasia. C stands for if the patient has recent usage of cautery, or sorry, catheterization, if there's a recent catheterization. And D, if the patient has underwent a digital rectal examination where you have stimulated the prostate, right? Now, beta less than 4 is considered to be normal, until 3.9 is considered to be normal. Okay? So, these are the components of PSA in general. Okay? Let's move on with the question. With a small tumor foci. Now, his Gleason score is 6. What is your most likely management? Now, here is an important component. The management of prostatic cancers do not really matter on the stage, but it does matter on the age of presentation. And the whole trick to this question lied in the first point itself, that is 75 years old patient. We wanted a patient who has to be less than 70. Low risk more than 70 hai, 75 nahi hai. So you need to look at the age of presentation. So that is why we have the criteria for management. Now, if you have a T1A disease, if you have a patient who is having a T1A disease, what is a T1A? It is incidentally detected post patient found to have, or we were thinking as BPH. We took the patient for transurethral resection of prostate. We got the prostatic chips, sent it for histopathology. On report, it came out to be as the prostatic cancer. Now, what will you do? I will only go with observation, nothing more. You have already removed the prostate, but again, we'll talk about this. Does TERP remains protective for prostatic cancer? The answer is no. We'll come across it. Now, if the stage is T1B, T2, T1C or T2, if the age is less than 70 years, then I will go with surgery, that is radical prostatectomy. But the same, if age is more than 70, I'll go with observation and follow-up. If it's a T3 or a T4 disease, irrespective of the age, I will prefer an hormonal therapy over radiotherapy if the receptor status is positive. If it is negative, then you have to go with radiotherapy. So here, age more than 70, that is 75 is there. So I will not like to do any surgery or radiation because it is not a very high component. Because for metastatic cancers, the PSA has to be more than 35. Brachytherapy is also not required here. So here only active surveillance. So answer here is going to be D for Delhi. Now, we spoke about Gleason's, right? So Gleason's is basically a pattern in which you are going to score your sample. So whatever biopsy component that you have taken, you have the Gleason's which are going to be in this particular form. Now, if the cells are well differentiated, it's good, a score of 1. If it is very, haphazard, unrecognized, a score of 5 is given. That means a lesser score indicates a better cell. That means a better integration. But if it is a higher score, that indicates that it is poorly differentiating. It is, the pattern is not there, the architectural distortion is there, all that is noticed. So all that you need to know, higher Gleason score, poor prognosis, lesser Gleason score or a smaller Gleason score has a better prognosis. Okay? So when you do a Gleason scoring, we have something called as the primary score and the secondary score, right? So we have the primary score and the secondary score. Now, what is this primary score and a secondary score? I hope everybody knows it, but a quick recap. Now, you take the histopathology or you take a sample and you look at the most common type of presentation that you have and the second most common type. We see the most common and the second most common type, and then we are going to score them, right? So a primary score can be anywhere between 1 to 5 based upon the pattern. and a secondary score also will be between 1 to 5 based upon the pattern of cell that you see. Now, when you look at this, whatever score you get, this is what we call it as the primary score, and whatever score you will get from here, this is what we call it as the secondary score. Now, a total score, if I say the minimum Gleason's, the minimum Gleason's that you can have is 2, and the maximum Gleason's that you can have is 10. But I will not write them as a whole number. I will write 2 as 1 plus 1, or I will write 10 as 5 plus 5. Now, why I am writing this way is whichever number you write first, this indicates the primary score, and whichever number you write next is called as secondary score, because the prognosis depends upon the primary score. Higher primary score indicates poor prognosis, and a lower secondary score. So when you have a tie which is there, let's say there are two patients, both their Gleason's are 7, right? Who is going to have a better prognosis? Whoever has a lesser primary score. Okay, the primary score is the detrimental factor. So that is why we have the Gleason's group, right? So you have grade 1 or the group 1 that is there, where our score is 6, written 3 plus 3, right? You have group 2, which is a Gleason's score of 7, but it is a favorable outcome. 3 plus 4 is your favorable outcome. And in the same grade 3, you have a total score of 7, but here you can see the primary score is more than the secondary. So it's an unfavorable outcome. It is an unfavorable outcome. Now, your Gleason 4, it is a score of 8. You can write 4 plus 4, that is the best one. Then you can write 3 plus 5, and then you have 5 plus 3. Next, your grade 5, this is more than or equal to 9. You can write 4 plus 5, 5 plus 4, or 5 plus 5, that is 10. So, higher score, poor prognosis. Okay? So, this is based upon the Gleason's that you have to vary across. So, all these are again important components, right? So, for any questions, any doubts? Now, this is again a previous exam question. Identify the gross specimen obtained from cystoprostatectomy, that means bladder with prostate. Just for the sake of orientation, this is the bladder specimen, and this is your prostate. Now, prostate looks fine, but you can see there is a mass in the bladder. So, it more or less gives you an idea that you're looking at bladder cancer, right? So, how does the other components look like is your exam component, or you need to look across? So, look at the image number 1. This is, you can see the polyp-like presentation is present, right? If you have bladder polyps, and that too multiple, then it is 𝐒𝐿𝐄𝐝. Now, if you have a completely occupied lesion, it is malignancy. For a prostatic cancer, you can see the bladder remains normal, but the prostatic infiltration, you can see the massy infiltration is there, and that is your prostate cancer. Schistosomiasis will have sandy patches. You can see here this small papules, and this cystitis wala jo component hai, that will be there in the schistosomiasis, right? Now, how do you manage your bladder cancer? Remember, stage T1 for bladder cancer. Stage T1 for bladder cancer will go intravesical chemotherapy or immunotherapy. We all know for immunotherapy, we will be giving intravesical. We will be giving intravesical BCG. We'll give intravesical injections of BCG. Now, this is usually given for 6 weeks. So, it's basically 1 injection per week. We'll give it for 6 weeks. Okay. Now, if you have a patient who is at T2 stage, for a T2, we'll go with radical cystectomy followed by radiotherapy. For T3 or a T4 disease, I will go with neoadjuvant chemotherapy followed by surgery followed by radiotherapy. What is the chemo regime? Remember, the chemo regime that we are going to follow is what we call it as the MVAC regime. In the MVAC regime, M stands for methotrexate, V is your vinblastine, A is your doxorubicin or adriamycin. C stands for cisplatin. So methotrexate, vinblastine, doxorubicin or adriamycin and cisplatin, right? So these are the components that you look at for bladder cancer. Okay? So moving to the next question. So if I number them for our safety, if I don't forget, this was question number 1 that we had. This is your question number 2. This is question number 3. This happens to be your question number 4. This is question number 5. And this is going to be question number 6. Take. Now, let's go to question number 6. I have a patient who has been in a road traffic accident with an abdominal pain. The resident examines the child and found the vitals are stable. Good news. Tenderness was present in the left lumbar region. What is the best investigation of choice? Blunt trauma abdomen, hemodynamically stable patient. You're looking at an organ injury. The best he's asking, not the first. The answer is going to be your CECT abdomen. End of discussion. इसके आगे बोलना ही नहीं है. So answer here is A for Ahmedabad. But you need to understand the protocols that we laid down for, right? So any patient who presents to you with blunt trauma abdomen, this is what the protocol looks like. This I've been repeating in my classes, in my lectures again and again. This is a classic from your Sabiston. So any patient of blunt trauma abdomen, you'll go with abdominal examination, look for peritonitis present or absent, hemodynamic stable or unstable. How do you do? You have, see, there's a notion नहीं कि fast करना है कि नहीं करना है. बेटा हर patient में ना blunt trauma abdomen, irrespective of the status, यहाँ पे add कर लो, you will take the patient. You will take the patient for fast. That is a focused assessment with sonography in trauma. Fast has to be done. Fast positive, fast negative बाद में देखेंगे. ठीक है, तो यहाँ पे peritonitis है कि नहीं है, stability है, fast positive नहीं है. If peritonitis exists, or if the patient is hemodynamically unstable, or if the fast is positive and the patient is hemodynamically unstable, then you'll go with exploratory laparotomy. No peritonitis, hemodynamically stable, go with CT. CT में देखोगे hollow viscous perforation is present or not. No, then it is fine. Yes, take for exploration. No है तो look for solid organ injuries. No, manage the other injuries. Yes, then you look for any arterial blush is present or not. आर्टीरियल ब्लश का मतलब क्या है कि कॉन्ट्रास्ट एक्स्ट्राफेसिएट हो रहा है, कि मतलब क्या है कि वेसल इज इंजर्ड, देन यस गो विद इंटरवेंशनल रेडियोलॉजी टू एम्बोलाइज दैट वेसल. इफ नॉट, नॉन ऑपरेटिव मैनेजमेंट. ये जो आपका टेबल है ना, इसको 10 बार 15 बार 20 बार पढ़ो. इट इज इंपॉर्टेंट. The question will come from this algorithm. Same algorithm can be laid down for your penetrating trauma abdomen for a stab wound. So whenever the abdominal stab wound, सबसे important क्या है, किसी ने चाकू मारा, पेशेंट चाकू के साथ आया, क्या करना है, चाकू नहीं निकालना है. Don't remove the knife. That's the most important thing. Let it stay in the C2. Then look at the abdominal stab. अगर पेशेंट को shock, peritonitis, bowel is coming out, hemodynamic instability, free gas under diaphragm, take for exploratory laparotomy. आगे बकवास नहीं करना. But if the location of the injury is in the flank, is in on the anterior abdomen or in the thoraco-abdominal region. अगर flank में है, CT abdomen pelvis करोगे with rectal prolapse or rectal contrast, positive laparotomy, negative do a DC versus serial exam, right? Now, when you talk about the serial exams, you look for the other components as well. We'll talk about it. Anterior abdominal wall में अगर injury है, CT करोगे, local wound exploration, serial abdominal examination for 24 hours. If there is any peritonitis, do a diagnostic laparoscopy and then do an exploratory laparotomy. Negative है, DC serial examination with diagnostic laparoscopy is to be done. Thoraco-abdomen में क्या है? Evaluation of diaphragm. If the chest X-ray you will do for pneumothorax. Pericardial fast for cardiac injury. Diagnostic laparoscopy for your abdominal injuries to be done. Now this chart is also very, very important. You cannot afford to miss out. ठीक है, सबसे important क्या है? To look for the injured side. Flank है, anterior abdomen है कि thoraco-abdominal region है. ठीक है, the most tricky one will be thoraco-abdomen. So do pay a bit of attention to it. Clear? क्या हुआ? ठीक है, चल, ओके. Moving on to the question number 6 हो गया, तो this will become question number 7. What is happening? Okay. This is going to be question number 7. Okay. Chalo. So we have a patient, let's look at this, a patient with a rectal prolapse, okay, underwent a surgery. The post-operative image is given below. Identify the procedure. So in this, what I can see is I have the index finger in the anal verge or in the anal cavity, and then you can see there are two suture lines which are passing, and then there is a circlage there. Okay, so finger is there. There is two sutures which are coming out through the 12 o'clock position. Now this is your 𝐒𝐻 wiring. Now, 𝐒𝐻 wiring is also called as the anal N circle or the circlage. Okay. Now, couple of things that you need to know with respect to the rectal prolapse. We have various components here. We'll look across it. The surgical management of rectal prolapse, we have two approaches. Either it can be a perineal approach or it can be an abdominal approach. Just remember the names. What are the examples of the perineal approach? It is a 𝐒𝐻 wiring, Delrom's and Altemier's procedure. Abdominal approach is going to be your Wells technique as well as your Freichmann-Goldberg. Another one that is going to be your abdominal approach is going to be your Rebstein's. Your Rebstein's and the modified Rebstein's. Your Rebstein's and the modified Rebstein's, right? Now remember, perineal approach is usually preferred in old patients. It is usually preferred in old patients. Abdominal approach will be preferred in your young patients. It will be preferred in your young patients. Okay. Now another criteria is, how do you know whether you have a full thickness prolapse? How do you know you're dealing with a full thickness prolapse or whether you're dealing with a partial prolapse? Whether you're dealing with a full thickness prolapse or a partial prolapse. Now for a full thickness prolapse, remember, if the length of the prolapsing segment is more than 4 centimeters. Length of prolapsing segment. Partial prolapse if it is less than 4 centimeters. If the length of prolapsing segment. If the length of the prolapsing segment is less than 4 centimeters, then we call this as the partial prolapse. That's the only thing that you have to remember, and these are the surgical options that we have. Okay. Now, how does a stapler hemorrhoidectomy is done? This is the procedure. I just want you to recognize this particular image or a device. Then this is your circular stapler. This is your circular stapler device. Okay. Again, a spotter in your exam, very, very possible. Clear? So, now moving to the next question. So, question number 8. Now, here I have a patient present with the following: a motorcycle road traffic accident. There was no pain on injury, fine. Examination showed the blood at the tip of the urethral meatus. What will be your next step in the management? No pain is there. There is only blood at the tip of the urethral meatus. What is your next management? So when you talk about the urethral injuries, if I simply give you a component. Now, when we talk about the urethral injuries, we divide the urethral injuries into anterior and posterior. We divide them into anterior urethral injury, anterior urethral injury, and the posterior urethral injury, and the posterior urethral injury. Now, this anterior urethral injury is also called as the distal urethral injury. This is also referred to as the distal urethral injury. And the posterior urethral injury is what we call it as the proximal urethral injury, also referred to as the proximal urethral injury. Now, the objective here is, if you take this as a representation of the bladder, this will be your prostatic urethra, then you have the membranous urethra, then you see this curve, that is a bulbar urethra, and then you have your penile urethra that is present here. So, the part which is occupied here by the prostate gland will become the prostatic urethra, right. So, this is the prostatic urethra, and then you have the membranous urethra. So, if you look at the objective, this is the demarcating line which is dividing the prostatic urethra and the bulbar urethra. This is what we call it as the proximal urethra, or this is what we call it as the distal urethra. This is what we call it as the proximal urethra and the posterior urethral injury, correct. So, so this is what we call it as the proximal urethral injury, whereas the bulbar urethral injury as well as the penile urethral injury is what we call it as the anterior urethral injury. As simple as that, right. Now, what are the components? Let it be any side the injury is there, both of them will present to you with blood at urethral meatus. So, the first thing you will see, blood at urethral meatus. There will be presence of hematoma, and there will be inability to pass urine. There will be inability to pass urine. So, these are the three cardinal symptoms that a patient will present to you. Now, you will notice the blood at urethral meatus will be seen in both the conditions. The hematoma will be present here, but you will notice the bulbar injuries will be associated to have perineal hematomas. They will have perineal hematoma, whereas your membranous urethral injury will be associated to have the pelvic hematoma. They will have pelvic hematoma. Both of them will have inability to pass urine. Remember, most commonly for an anterior urethral injury will be your bulbar urethra. It will be your bulbar urethra, and the most commonly for these or posterior urethral or the proximal one will be your membranous urethra. It is going to be your membranous urethra, right. So, these are the differentiating components that you will have with respect to the urethral injuries, right. Now, I have given you the same in a tabular column, but how do you recognize it? So, on a uretherogram, you will notice that I have given, see, this hunch is what we call it as the bulbar urethra. That is what, remember. Then you have membranous, then the prostatic. What is the verumontanum? It is the anatomical landmark to know whether you are at the prostatic urethra or not. Then into the bladder. Now, when you give the images, now there are two images which are there, the image number 1 and the image number 2. Now, see very carefully, right. So, in the image number 1, if I map it across, this is your penile urethra, which is fine. There is no extravasation. Penile urethra is fine. Then you see this hunch that is present. This is what we call it as the bulbar urethra. The bulbar urethra also looks fine. There is contrast extravasation, and this contrast extravasation is seen in the membranous urethra. This is noticed in the membranous urethra. So, this is your membranous urethral injury, and then the last one that you have, this is your prostatic urethra. This happens to be your prostatic urethra. But you come to image number 2, you can see the penile urethra, it is fine. This is the penile urethra. But when you see, this is my bulbar urethra, which is taking this loop that is present. This is, and you can see it's a loss of segment. There is contra extravasation. So this is your bulbar urethral injury. This will have your bulbar urethral injuries. Okay? So this is how you differentiate between the penile urethral, your bulbar urethral injury and the membranous urethral injury based upon the ureterogram. Clear? Sure. So this is a question number 8. So what will you do? Now here the question says the patient only, no pain is there. There's blood at the meatus. What will be? See, remember, Foley's catheterization is contraindicated in urethral injuries. It is contraindicated in urethral injury. Now wait and watch can be done. Nephrogram, there is no need because kidneys are not damaged. Suprapubic cystostomy, if it is retention of urine. If there is retention of urine, and whenever there is retention of urine, this will be associated with pain, and here in our patient there is no pain, so answer here is going to be B for Bombay. It is going to be B for Bombay. Okay, sure. Okay, somebody has a question, sir, should we practice slot pattern MCQs or GT? Beta, slot pattern GTs, again, when you are going to write the exam, you need to have net practice. एग्जाम में जो माहौल बनेगा, एग्जाम में जो स्ट्रेस होगा, एग्जाम में जो क्वेश्चंस होंगे, वही आपको यहाँ इम्यूलेट करना है. Now, lot of students know, as we've been interacting since the notice is out, lot of you are asking कि sir, shall I practice 40 questions वाला slot? तो आई आज कैसे प्रैक्टिस करोगे? बोलते सर देखो, जैसे आज मैं मेडिसिन पढ़ रहा हूँ तो मेडिसिन के 40-40 करता रहता हूँ, फिर सर्जरी के, उसके बाद आई डू रेस्ट ऑफ द सब्जेक्ट्स. ऐसे नहीं होता बेटा, क्योंकि क्या होता है ना, व्हेन यू स्टार्ट डूइंग वन पर्टिकुलर टॉपिक और वन पर्टिकुलर सब्जेक्ट, नो, because you have known that topic or that subject, you'll be able to perform better. आपका stress level कम होगा. See, you need to train your mind to switch also. मतलब मेडिसिन से बायोकेम में स्विच कर रहे हो, बायोकेम से एनाटॉमी में स्विच कर रहे हो, एनाटॉमी से सर्जरी में, सर्जरी से ऑफ्था में जा रहे हो. दैट इज हाउ द क्वेश्चंस विल बी देयर इन द एग्जाम, नो, जम्बल्ड फैशन में. इसीलिए स्लॉटिंग जीटी का बेटर है वेदर कंपेयर टू योर इंडिविजुअल सब्जेक्ट स्लॉटिंग. सिंगल सब्जेक्ट स्लॉटिंग में क्या होगा ना, जैसे आप क्वेश्चन करते रहोगे ना, 40 क्वेश्चन आप बड़े आराम से कर लो, क्योंकि यार जैसे अभी ब्रेस्ट पढ़ा है, ब्रेस्ट में 40 क्वेश्चन ऐसे निकलते हैं, तो आपको लगेगा यार 40 मिनट थे, मैंने 40 क्वेश्चन 15 मिनट में कर लिए. दैट गिव्स यू सूडो कॉन्फिडेंस. ठीक है, सो द मोस्ट इंपॉर्टेंट थिंग इज टू हैव दैट पैटर्न इज ऑल्सो इंपॉर्टेंट. मतलब वो फेथ भी इंपॉर्टेंट, वो कॉन्फिडेंस बना के रखना है, लेकिन सूडो कॉन्फिडेंस नहीं लेना है. ठीक है, तो स्लॉटिंग जीटी की करेंगे और जीटी में ही आंसर करेंगे. दैट इज द मोस्ट इंपॉर्टेंट एडवाइस. ठीक है, चलो, कैन वी मूव ऑन? Now, let's move on to question number 9. Right? Now, in question number 9, I have a patient presents with hernia medial to inferior epigastric artery. What is the most likely diagnosis and the appropriate management for the same? Now, how do you differentiate direct and indirect inguinal hernia? That has been a very, very repeatedly asked question. So let's understand this way. Now, imagine that we're talking about the inguinal canal. Okay, I'll use a different color. Let's talk about the inguinal canal. This is your external oblique aponeurosis and this is your superficial inguinal ring, right? Behind this, let's say you have, this is the fascia transversalis and this is the defect in the fascia transversalis and this continues together. That's your posterior wall, right? Now, this is covered by your peritoneum. This is the medial end that you have. So, in the medial end of it, let's say this happens to be your, we'll keep it this way. Let's say this happens to be your pubic tubercle. This is the pubic symphysis and we're saying this is the pubic rami that is present. Okay? This is the whole component that you have and this will be your pubic bone. Just for the sake of understanding. Okay? Achha. Now, right in the center, now if we take the midline, just for the sake of understanding, let's say this happens to be the midline that we're talking about. You have a muscle that is going to be present, and that muscle is going to be your rectus abdominis muscle, and let's say this is the orientation of the rectus abdominis muscle, right? So this is your rectus abdominis muscle that is going to be present. Now, there is a blood vessel that is going to originate from here, that is your inferior epigastric artery, which is going to travel in this particular fashion, right? So the inferior epigastric artery is a branch of external iliac artery. Okay? Now, you have the inferior epigastric artery which is present here, right? This is the inferior epigastric artery, and then you have, let's say, whatever comes on this side of it will become medial, and whatever is here will say the lateral component. Now, in an indirect inguinal hernia, we notice that the hernia that is going to occur will arise through, let's say, we're talking about a bowel that is present, and this bowel is exerting pressure at the deep inguinal ring to cause the hernia. So, what is going to happen? The hernia, when it occurs, you will notice. Before we move across, the content is also important. Let's make the content here. It is going to be the vas deferens, and this is how the cord is going to run across. This is the vas deferens, right? You have another component, that is your ilioinguinal nerve. I'm not going to go into details. Now, when the hernia is going to arise, you will see the peritoneum that is present is going to move into deep inguinal ring, will travel through the inguinal canal, and then you will notice that it is going to outpouch from here. So, long story short, you will notice that whatever is inside this component is going to go along. So, the peritoneum is outpouching. Why the peritoneum is outpouching? It is outpouching because the bowel that is exerting pressure on it. So, along with this, you will also notice that the bowel that is present here will also travel. It could be bowel, it could be omentum. I'm just giving you a component here, and this component is going to travel all the way into the sac, and then you see the content is being delivered into the sac that is present, right? So, this is how an indirect inguinal hernia is going to look like. On the other hand, if I say how does a direct inguinal hernia will look like? Now, in a direct inguinal hernia, what changes will be there? So, in the direct inguinal hernia, everything else remains the same. You see, this is the cord that is present, which is we have. Now, the defect in the direct inguinal hernia is from the posterior wall, that is a Hasselbalch's triangle, and we all know the Hasselbalch's triangle is between the inferior epigastric artery. If you want me to mark it down for you, the Hasselbalch's triangle is formed by your inferior epigastric artery, which is present here. The lateral border, it is formed by the lateral border of the rectus abdominis muscle and the inguinal canal. So, there is an area of weakness. Now, what is going to happen? This area of weakness will be explored by the bowel that is present here. So, because of extensive pressure, you will notice that the fascia transversalis is going to pouch out. Along with that, you will notice the peritoneum is going to follow this, which is going to be here. And whatever is the content, let's say the bowel that is here, the bowel will go along with this, and the content will be present, right? Now, this is how a direct inguinal hernia would look like, right? Now, if you look at the indirect and the direct inguinal hernia, indirect, when say, again, the classifying points in the direct and indirect, if I simply give across. Now, we say the entry point of this is your indirect inguinal hernia, and this happens to be your direct inguinal hernia. Let's understand both. Now, in an indirect inguinal hernia, the entry is from the deep inguinal ring, right? So, this is the entry point. Exit is from The exit is from the superficial inguinal ring. Now this is what we call it as the sac, right? So the sac of the indirect inguinal hernia is made up of, it is made up of peritoneum, right? As you know, this is the peritoneum that you have. Now this happens to be your fascia transversalis, and this is your external oblique aponeurosis. This is your external oblique aponeurosis. Okay? Now the sac is made up of peritoneum. You will notice that relationship of the neck with respect to inferior epigastric artery. Neck is the narrowest part that you have. The neck is at a deep inguinal ring. So when you talk about the relation of neck with respect to inferior epigastric artery, you see the neck of hernia. The neck of hernia lies lateral to inferior epigastric artery. But on the other hand, if you look at the sac, and this is your vas deferens. Now, when you look at the sac, you see here the vas deferens lies medial to sac. Now, this is your trick question. Okay? Clear? Clear? So the entry is from the deep inguinal ring, exit is from the superficial inguinal ring, sac is made up of peritoneum, the neck lies lateral to inferior epigastric artery, whereas the vas deferens lies medial to the sac. Okay? All these are the important components. Now, अगर यही आप direct inguinal hernia में देखोगे, ठीक है? So when you talk about in the direct inguinal hernia, everything if okay. So in the direct inguinal hernia, same thing. When you talk about the entry point, we talk about the entry point. Okay, बाद में miss ना हो जाए. एक से. In the direct inguinal hernia, again same thing. We talk about the entry point. The entry is through the Hasselbalch's triangle. It is through the Hasselbalch's triangle. और ये आपका posterior wall है, ठीक है? Exit जो है that will be from your superficial inguinal ring. If you say the sac here, it is made up of fascia transversalis. So sac is made up of fascia transversalis, ठीक है? Now, when you look at the neck of the direct inguinal hernia, so यहाँ पे जो orientation है, neck lies medial to inferior epigastric artery. Neck lies medial to inferior epigastric artery. But अगर आप ये notice करोगे, the vas deferens, here the vas deferens lies lateral, it lies lateral to sac. ठीक है? So these are the important components that you need to differentiate. ठीक है? इतना समझ में आ गया, hernia में और कुछ है ही नहीं समझने के लिए. ठीक है? Now the question is, here it says that hernia, patient present with hernia medial to inferior epigastric artery. अगर medial होगा तो direct होगा, तो answer here has to be direct. तो हमारे पास direct के दो option, direct hernia is here, so it cannot be indirect. ठीक है? अगर वो lateral to inferior epigastric artery होता तो indirect होता, because it is medial, it is going to be direct. Basini's is not done any longer. We need mesh. So here currently your Lichen-Stein tension-free mesh repair is the answer. It is going to be B for Bombay. As simple as that. Now, अगर आप previously देखोगे, in the component of hernia, no, क्या क्या पूछा हुआ? Now, the first thing is about the mesh. What is an ideal mesh or the characteristic of ideal mesh? The characteristic of ideal mesh. Number one, it should be non-absorbable. It should be non-absorbable. It should be lightweight. It should be lightweight, that is less than 40 grams per meter square. It should be lightweight. It should have large pores, that is macroporous. It should have large pore, that is macroporous. Non-absorbable, light-weighted, large pored. This should be hydrophobic. It should repel water, right? And it should be Okay. So it should be non-absorbable, it should be light-weighted, large-pored and hydrophobic, right? Most commonly used material in hernia repair, it is going to be the Prolene mesh. It is going to be Prolene mesh, right? How much percentage of mesh shrink is appreciated or predicted? Remember, approximately 50% will be the mesh shrinkage. Okay. Achha. Now you have classification which is called as the European Hernia Society. Now, according to the European Hernia Society, the classification is done whether it is a primary or a secondary or a recurrent hernia. Whether it is a lateral, or medial hernia, that is midline. And the defect is given as 1.5 centimeters is equal to 1 defect. It is given as 1.5 centimeters, 1 defect. ठीक है. Now, अगर आपके पास है, when I say lateral hernias or your inguinal hernias, medial hernias are your ventral hernias, right? Ventral is your epigastric hernia, your umbilical hernias and all. Now, if I have a patient where I say that the patient is presented to you with a hernia society classification of PL2. Now, P indicates that it is a primary hernia, right? L indicates that it is lateral, that is your inguinal hernia. That is your inguinal hernia. And 2 indicates that there are 2 defects, right? Or 2 finger breadth. 1 finger breadth is equal to 1.5. 1.5 centimeters is equal to 1 single defect, or 1 defect is equal to 1 finger breadth. Now, when we say 2, that means 2 finger breadth, that is 2 into 1.5 centimeters. 2 into 1.5 centimeters will be the total defect. So, total defect of 3 centimeters. So, it's a primary inguinal 3 centimeter defect hernia, and this is your hernia society classification. Okay? So, this is something that they ask you on a regular basis. Now, so this was your question number 9. Then you go to question number 10. Now, in question number 10, what do we have? I have a patient, road traffic accident, presented with subcutaneous emphysema. Auscultation, there was no air entry on the right side. Vitals were unstable. What is your immediate management? Okay. Now, this is a classical case of traumatic thoracic injuries. Okay. So, in the traumatic thoracic injuries, I want you to differentiate between the tension pneumothorax, and open pneumothorax. It is your tension pneumothorax and the open pneumothorax. Now, in a tension pneumothorax, let's understand the whole concept behind the component here. Now, let's say this happens to be the thoracic cavity that we're talking about. Now, let's say this is what we're talking about as the lungs which are present. Right, and let's say this happens to be the trachea that is there. One second. Okay. So let's say these are the lungs which are present. The green one is the pleura, that is your visceral pleura to which it is attached to. Then you have another pleura that is present which is called as a parietal pleura, and the orange one depicts that this is the parietal pleura that is present. So this is the parietal pleura that you have, and this is the visceral pleura that is present. And let's say that this happens to be the trachea. Again, these are the components which are going to look like trachea. ठीक है, ये tracheal component. Now, how do you differentiate between a tension and an open pneumothorax? It is purely on the mode of injury. This is the lung that we're talking about. Okay. Now, so when we say the difference between the tension and the open pneumothorax is, tension pneumothorax, the injury occurs within the thoracic cavity. Now, once the injury occurs, right, let's say there is an injury that has occurred. Once the injury occurs, let's say there's an injury that has occurred in the parenchyma. So what is going to happen as the injury is going to occur, you will notice that the air which is present here will start leaking now. You see the air will start leaking between the parietal and the visceral pleura. As more and more amount of air is going to leak, you will see that this entire side of the lung will now be filled up with the air. Now this occupies the entire space and it is compressing the lung and not allowing the lung to expand. So in a tension pneumothorax, you notice that the air that is leaking out, that air leak is occurring from within the cavity. It is occurring within the cavity, and this air leak that is present is compressing the lung itself and not allowing the patient to breathe. So tension pneumothorax का जो concept है, that you can see that the lung is being compressed. You see the lung is being compressed within the thoracic cavity. The lung is being compressed from within thoracic cavity as the air is going to leak out, right? This is your tension pneumothorax. Open pneumothorax का जो concept है, it occurs that somebody has stabbed. किसी ने चाकू लिया, चाकू मारा, and उस चाकू की वजह से यहाँ पे injury होगी. Now this has created an opening here. Now, as it has created an opening, we all know there's a negative pressure in the thorax. Now, because of negative pressure inside the thorax, the air from the external environment will be sucked in. Now, there's an important concept. If I take a small needle and puncture, will the air start coming in? The answer is no. So, what is the criteria? The criteria is, remember, either it should be more than 3 centimeters in size or more than 2/3 of the tracheal diameter. More than 2/3 of the tracheal diameter. This is the wound that has to be created. Because it is sucking the air from outside, this is also given a nickname of sucking chest wound. It is also referred to as a sucking chest wound. So it sucks the air into the thoracic cavity. Now, as the air moves in, you see that this air is going to fill up. This air is going to fill up the entire thoracic cavity. Whatever happened in the tension pneumothorax, the same thing is going to happen, but the process of happening is going to be slightly different, right? So this is how you see the lung is getting compressed, and this is the visceral pleura that is present. So when you look at this in tension and open pneumothorax, both of them, the air is getting filled. It is compressing the lungs, not allowing the lungs to expand. Hence, there will be respiratory distress. But here, the tension pneumothorax, air is leaking within the thoracic cavity. In open, the air is coming from outside. So the question is very simple. Which of these two is regulatable? Is it the tension or the open pneumothorax? Remember, it is the open pneumothorax that is regulatable. All that you have to do is ask your patient to put a hand. आप पेशेंट को क्या बोलना है कि यहाँ पे हाथ रखो ताकि हवा बाहर से अंदर ना जाए और आपका pneumothorax मेंटेन रहेगा. कम नहीं होगा लेकिन ज्यादा नहीं होगा. और टेंशन में प्रॉब्लम क्या है? With every single breath the patient takes, हर बार ब्रीथ लेगा, सांस अंदर जाएगी और वो लीक करेगी. राइट? There is no way you can regulate. The only way you can regulate is ask your patient not to breathe. बोला भाई सांस मत ले, ठीक है, टेंशन नहीं मतलब रुक जाएगा. अब सांस लेगा तो पेशेंट ही नहीं रहेगा. राइट? इट्स द सेम कॉन्टेक्स्ट. राइट? Now, in that context, remember tension pneumothorax, but a pleurodase is done when there's a constant air leak. We'll talk about it. Now, in tension pneumothorax, the air is leaking within. Open pneumothorax, air is coming from external environment. This is the concept that you remember. Okay? Now, either ways, when you look at the open or a tension pneumothorax, their presentation is going to be quite similar. Right? Both in a tension pneumothorax, the patient will present to you with dyspnea. Right? There will be presence to you with tachypnea. There will be dyspnea, there will be tachypnea. Now, in the thorax, there is negative pressure because of the air filling, it is becoming positive. It will compress the head and neck veins that are supposed to drain. So, there are distended neck veins. There will be presence of distended neck veins which are present. Along with distended neck veins, what else will you see? Right? Another thing that you will notice in a tension pneumothorax is that when you're auscultating, no, because this side में air high नहीं, so obviously on auscultation what will you get? There is absent or decreased air entry on the affected side. On the affected side. Now, because the air is going to push the trachea to the opposite side, you will see the trachea deviated. The trachea deviated to opposite side. Right? On percussion, you will see hyper resonant. You will see presence of hyper resonant node. Right? All these findings, you will see dyspnea will be present, tachypnea will be present, distended neck veins will be present, air entry will be absent, trachea will be deviated, hyper resonant node. But additionally, you will see presence of an open sucking chest wound. And this is how you differentiate between open and tension pneumothorax. Okay? Open as well as tension pneumothorax. Clear? Now, remember on either cases, when we say in emergency, what are we going to do in emergency and what are we going to do as an elective form? Now, in an emergency, I will do a needle thoracocentesis. Elective, I will do as, rather than say elective, it's a definitive. As definitive, I'll do an ICD management. Okay? So, emergency mein you will do a needle thoracocentesis. So, in needle thoracocentesis, we will see whether you are looking at an adult or a child. In the adult, the needle is going to be put in the 5th intercostal space of mid-axillary line. Child may, it is going to be the 2nd intercostal space in mid-clavicular line. In the mid-clavicular line. Whereas when you talk about definitive, then I have to put an ICD, that is your intercostal drain. ICD stands for an intercostal drain, and ICD is an intercostal drain. Now, the ICD that is put in adult is preferred at a 28 French, and in a child, I would prefer an 18 French. Okay. Now, where would you insert this? There's something called as the safety triangle for the ICD insertion. Now, the safety triangle will be seen on the lateral side. If you look at the boundaries of the safety triangle, this is the anterior boundary, this is the inferior boundary, this is going to be the posterior boundary, right? The anterior one, this is the posterior one, this is the inferior. Anterior is formed by the pectoralis major muscle. Posterior is formed by the latissimus dorsi muscle. inferiorly it is formed by the 6th rib, and this is your 5th intercostal space. Now in the 5th intercostal space, this is going to be your mid axillary line, and this is where you are going to put the ICD, right? So in the 5th intercostal space, we're going to put in the 5th intercostal space in the mid axillary line, which is guarded anteriorly by pectoralis major, posteriorly by latissimus dorsi, is where you are going to put a definitive ICD. Clear? Okay. So this is with respect to your pneumothorax management. So let's come back to the question. Question क्या बोल रहा है? It says patient road traffic accident, subcutaneous emphysema. On auscultation, no air entry, vitals unstable. This is important. What will be your immediate management? If it is unstable, what would you like to do? Would you like to insert a wide bore needle in the 5th intercostal space? Now, a patient subcutaneous, he did not give the age. I'm assuming it to be adult. I can do this. Wide bore needle decompression and IV fluids. Again, not a precise option. Intubate with positive pressure, not a precise option. E-fast, if you are talking about immediate management, he is asking. E-fast is not a management, it is a diagnostic tool. So answer here is going to be A for Ahmedabad, right? So I would like to insert a wide bore needle in the 5th intercostal space, let it vent out. Okay? So venting is important so that it decompress. Clear? Sure. So this was question number 10. So this will become question number 11. Okay? Now what does question number 11 says? I have a 54-year-old female, abdominal pain, bilious vomiting, history of abdominal hysterectomy 2 years back, right? On examination, abdomen auscultation revealed high-pitched bowel sounds. Investigation showed air within the biliary tree. What is the most likely diagnosis? So if I don't consider air into the biliary tree, no, I was thinking more or less in the form of abdominal or small bowel obstruction due to adhesions. But air in the biliary tree, this is your pickup point. This tells you patient is having pneumobilia. Along with pneumobilia, all this abdominal pain, bilious vomiting, this is telling you patient is having a small bowel dynamic obstruction. It is telling you there is a small bowel dynamic obstruction. Now this is pointing towards a condition that is called as Gallstone ileus, right? So quickly looking at what are the components of Gallstone ileus. Now when I say a Gallstone ileus, the most common cause for Gallstone ileus, it is because of I can say entero or bilioenteric fistula. It is because of bilioenteric fistula. Now, where do you see this? What is the most common site? It is between the gallbladder and the duodenum. That is a cysto, or I can say the cholecystoduodenal fistula. It is your cholecystoduodenal fistula. It is your cholecystoduodenal fistula. What is the risk factor? Risk factor is presence of gallstones. Presence of gallstones, diabetes is also considered to be a risk factor. It is usually seen more common in females when compared to males, and the usual age of presentation is seen in age above 50 years, right? Now, when you look at the gallstone ileus, I hope you know the basic objective behind it, but when you say gallstone ileus, it is associated with a triad that is called as a Regler's triad. In the Regler's triad, the patient will present to you with features suggestive of small intestinal dynamic obstruction. On radiology, there will be presence of pneumobilia, and when you do an exploratory laparotomy, you will see presence of ectopic gallstones. Presence of ectopic gallstone. That is your Regler's triad. Okay. So when you take this component, this is your Gallstone ileus. All this data of Gallstone ileus is an important component to be remembered. So here the answer is Gallstone ileus. It cannot be an additional, adhesive intestinal obstruction. Yes, post-operative is a common component, but pneumobilia is not seen, right? Ischemic enterocolitis is going to present to you with diarrhea, and that too blood with severe abdominal pain. Diverticulitis will associate with fever, it can associate with diarrhea, associated with blood loss, but not pneumobilia. So hence the answer is Gallstone ileus, right? All these important components are important. So going to question number 12. This is your question number 12. Now, in question number 12, I have a patient with abdominal pain, sterile pyuria, which are the following findings shown in the image given. Now, you can see in the image given, it's a very classical image of putty kidney. And putty kidney is a characteristic feature of tuberculosis. That is your TB kidney. Putty kidney is a characteristic feature of your TB kidney. बेटा ileus में the air gets trapped, और यहाँ पे gallstone ileus is a misnomer. Dynamic obstruction है, the gallstones are causing obstruction, so air gets trapped into small bowel, and whenever there is distension, when you do percussion, obviously air की वजह से node will get high pitch. No, resonance को high pitch बोलते हैं, ठीक है? So this is your putty kidney that you have, and putty kidney is seen in tuberculosis, and sterile pyuria is also seen in tuberculosis, right? So sterile pyuria is an important pickup point here. So sterile pyuria is a component that you need to look up to. Clear, guys? Okay. Now, what are the other findings that you have? This is a classic of staghorn calculi. As you can see, it is giving you a nice pictured formation here of staghorn, right? In fact, here you can see it's a bilateral staghorn presentation, and staghorn calculi, it is seen in triple phosphate stone. It is seen in triple phosphate stone. It is seen in triple phosphate stone, right? Or also commonly referred to as the struvite stone. Also referred to as the struvite stone. It is called as the triple stone because it consists of the ammonium crystals, it consists of the phosphate crystals and the magnesium crystals. Because it has got three different salts, it is called as the triple stones, right? The most common cause is phosphate stone is going to be infection, and the most common organism causing this is your Proteus bacteria. Now remember, phosphate stones are the most radio-opaque stones. They are considered to be as the most radio-opaque stones. But if I say what is the most common stone, the most common stone will be your calcium oxalate stone. That will be your calcium oxalate stone. The most common is going to be the calcium oxalate stone. The most common is going to be calcium oxalate stone. But if I change the question, what is the most common radiolucent stone? The most common radiolucent stone, it is going to be the uric acid stone. This is going to be the uric acid stone. The most common radiolucent stone will be your uric acid stone. Clear? Take. Sure. Now you see this particular image where you see a calcified lesion on the medial aspect and the orientation is towards this side. Take a medial orientation. This is basically a psoas calcification. It is very unlikely that they will ask you a question like this because there was an option, so I just put an image of psoas calcification. Now this psoas calcification is because of chronic abscess. It can be a result of chronic abscess. Okay. Now, this is the image of your putty kidney. It's a ball of cotton, like cotton wool ball, usko putty kidney बोलते हैं. Now, putty kidney has something called as, it is because of TB, so it is also called as TB kidney. Now, as we have come across a word that is called as sterile pyuria. Now, what is the sterile pyuria is? Here you will say, when the microbiology see, there will be presence of pus cells. You will see the pus cells are present, but you will notice the organism is going to be absent. The pus cells are present and the organisms are absent. So, presence of pus cells and the organisms are absent. Okay. So, what are the other conditions that you will see presence of sterile pyuria? It is referred to as a small mnemonic, that is RT. Now, R stands for in renal stones. T stands for tubercular kidney, that is TB kidney. I stands for incompletely treated UTI. Incompletely treated UTI. N stands for interstitial nephritis. It is an interstitial nephritis, and A stands for analgesic nephropathy. A stands for analgesic nephropathy. Okay. So, this is with respect to sterile pyuria. Again, this slide is very, very important. Everything that is relevant for the exam point is being summarized across here. Okay. Sure. So, that was your question number 12. Moving to question number 13. Now, in question number 13, a patient was found to have a mass arising from the antrum of the stomach, which involved the head of the pancreas and metastasis to the right lobe of the liver. So, it is a metastatic lesion. Okay. So, how will you manage? So, you are talking about the management of metastatic gastric cancers. I have given you a few important components. So, with respect to the TNM classification, now, in the TNM classification, we say if it is T1A lamina propria, 1B is going to be submucosa, T2 is muscularis propria, T3 is serosa, T4A perforate serosa, T4B involvement of adjacent organs, pancreas is getting involved, so it's a T4B here. N1, 1 to 2 regional lymph nodes, N2 is 3 to 6, N3A 7 to 15, N3B is more than 15, M0 no evidence, M1 there is distant metastasis. So, here the diagnosis that we get is T4B and M1 lesion is present. Now, it's a simple context. We say operable, inoperable tumors less than or equal to T3, N1, N2 is operable, more than or equal to T4 or N3 or M1, it is inoperable. R state is inoperable malignancies. This is your Sievert classification for your GE junction. Again, an important component from the exam. How would you like to manage? If it's a proximal tumor that is present in the proximal stomach, total gastric is ruined by, mid body is total gastric is ruined by, distal is going to be subtotal. Early gastric cancer, how do you define early gastric? T1A less than or equal to 2 centimeters, intestinal type of adenocarcinoma, absence of lymphovascular spread is your early gastric cancer. You can do an EMR, that is endoscopic mucosal resection. Our patient right now has what? He has your T4 disease, right? A T4 disease is considered to be inoperable. Inoperable kya karoge? The only thing I can do is a palliative gastrointestinal followed by chemotherapy. The reason I'm doing a palliative, I'll not do radical, I'll not do Whipple's, I'll not do hepatectomy. Remember, if it is a colorectal cancer with liver metastasis, I can do a metastatectomy in terms of liver resection, but in gastric cancers, it is not. So, answer here is going to be A for Ahmedabad. Gastric cancers are going to be important. Look for Lawrence classification. That's a revision point also. Question number 14. Now, in a question number 14, what do you have? I have a patient who has underwent cholecystectomy for gallstones 2 years ago. She now presents with symptoms of obstructive jaundice. Investigation revealed a stone in the CBD that is present. What is the stone most likely to be? Now, primary stones, let's understand the definition. Primary stones क्या है? Stones that develop within CBD, right? Secondary क्या है? Stones formed in gallbladder and lodged into CBD. Retained क्या है? Presence of CBD stone within 2 years. Within 2 years of cholecystectomy. Within 2 years of cholecystectomy. And another important thing, retained, it should be a non-pigmented, that is, it should not be a non-brown pigmented stones, because brown pigmented stones are found in an infected bile, and that can be seen, or that infected bile can be seen in any CBD obstruction. Okay? It could be a stricture also. So here underwent cholecystectomy is done. So post cholecystectomy for gallstones 2 years ago. So it is more than 2 years. No, 2 साल पहले की बात है, मतलब 2 साल हो गए. So it cannot be a retained one. It cannot be secondary because gallbladder is not there. So it is your primary CBD stones. It's a primary CBD stones. Okay? Now, okay. So when you talk about the CBD stones, now CBD stones can present to you as an asymptomatic presentation. They can be asymptomatic like incidental finding. They can present to you with obstructive jaundice, and they can present to you with a full-blown cholangitis. Now, if cholangitis is untreated, it is 100% fatal. It is very, very, very important. Okay? Now, how can a CBD stone be asymptomatic? The concept is very simple. Now, when you look at the gallbladder, this is the orientation of the gallbladder. This is the cystic duct. This happens to be your common hepatic duct, and this is your common bile duct. Okay? Now, for the sake of understanding, this is your right and the left hepatic duct. So, this is the objective here. Now, when you talk about the cystic duct, this is a cystic duct. Remember, the cystic duct is 3 millimeters in diameter, whereas your CBD is approximately 7 millimeters in diameter. And whatever stones which are going to be present, whenever a stone is going to pass out from the cystic duct into the CBD, what will be the size of the stone? Will it be more than 3 millimeters or less than 3 millimeters? Now, obviously, for a stone to pass from the cystic duct into the common bile duct, it has to be less than 3 millimeters. Can a stone which is less than 3 millimeters cause an obstruction in a duct which is 7 millimeters? The answer is no. Hence, it usually passes, so no symptoms at all. But if it gets lodged, it can present with obstructive jaundice, but we are more concerned whether it goes with cholangitis. Now, in a cholangitis, the patient is going to land up with Charcot's triad. Now, this Charcot's triad will have 3 symptoms, like it will be an intermittent component, it will have an intermittent pain, fever, and jaundice. If it is left untreated, it will add 2 more things: altered sensorium. It will add altered sensorium with sepsis. And if all 5 of them are added, this is what we call it as the Reynolds pentad. This is what we call it as the Reynolds pentad. Okay. So this is the important aspects that you should evaluate here, right? So answer here is going to be primary stones. So that's a question number 14. We're going to question number 15. Now, in question number 15, I have a 70-year-old female presents with pain in the thigh during walking, right? Now, investigation reveals the following given below. What is the best surgical management? Now, when you look across this particular component, this happens to be the aorta, this is the common iliac, and this is your internal and this is your external iliac. Okay? So you see the contrast has a cutoff at the level where it is going from iliac to the division of the internal and external iliac. This is your external iliac, this is your internal iliac. So this will be your common iliac, right? So the occlusion is present at the level of iliac, right? So you have three sites of occlusion that we'll discuss. So right now I know the occlusion is present at the common iliac. So this is your common iliac occlusion. This is your common iliac occlusion, right? So let's understand that what are the best objectives that you have. So you have three sites for obstruction. You have the iliac obstruction, you have the common iliac occlusion, and the femoropopliteal occlusion, which is present here, right? Now, remember, whenever we talk about the presentation, we'll be talking about the status. Now, when you talk about the intermittent claudication, this claudication is intermittent. Now, this is going to be an intermittent claudication. Now, in an intermittent claudication, we're talking about the sites of occlusion which is present here. The first one is your iliac, which is here. Something is not setting properly. So you have the iliac occlusion, which is here, the iliac occlusion, which is here, and the femoropopliteal occlusion, which is here. Okay. Now, when you talk about the intermittent claudication, in iliac you have bilateral intermittent claudication. Here you have unilateral intermittent claudication, here also unilateral, because in iliac, blood supply to both the vessels are going to get hampered, whereas in iliac and femoral, only one side is getting hampered. Now, here there will be involvement of thigh, involvement of calf, there will be involvement of ankle. Here there will be another muscle that is to be considered is gluteus. So remember, here in iliac occlusions, the gluteus would be spared, whereas the calf, ankle would be involved. Here gluteus, thigh is spared, the calf is also spared, only the ankle is involved. Now, how would you do a bypass? Here we do an iliopofemoral bypass. Here we do only iliopofemoral bypass. Here we do an iliopopliteal bypass, right? So here I am going to do an iliopofemoral bypass. It's an iliopofemoral bypass. Here I will do an iliopofemoral bypass, and here I'll do an iliopopliteal bypass. Here I'll do an iliopopliteal bypass. Clear? So this is how we'll look across here. So our question had iliac occlusion. So for iliac occlusion, I'll do a iliopofemoral bypass. So answer here is going to be C for Calcutta. Okay. Chalo. Femoroiliac bypass is done if it is a femoropopliteal occlusion. If it's a femoropopliteal occlusion, iliac we don't do it. We'll do only an iliopofemoral bypass. Okay. Now, this was your question number 15. Moving to question number 16. Now, according to the SEEP classification, what will be the C stage of this particular patient? Now here what do you see? I only see varicose vein, nothing else. So this is the varicosities that are seen across here. So in varicose, what is the component? So let's see what are the options given and try to soothe it across, right? So when we say the classification, that is, we have C2 is your varicose vein. C2S is your recurrent or secondary varicose vein. C4A is presence of pigmentation, and C1 is presence of telangiectasia. It is telangiectasia or reticular veins, right? So here in the image we have varicose vein. And there is no mention that is reoccurring after the surgery. So hence it is going to be option A, that is a C2A classification. It basically you have C2 or C2R. C2 is varicose and C2S is your recurrent varicose. I've given you the C classification, same thing. C1 is telangiectasia reticular veins, C2 is varicose, recurrent is C2R, C3 is edema, 4A is pigmentation, lipodermatosclerosis, 4B, 4C is coronophlebectatica, C5 is healed ulcer, C6 is your active venous ulcer, C6R is your recurrent venous ulcer. On the basis of etiology, C is congenital, P primary, S is secondary. Anatomy, AS is superficial, AD is your deep system, AP is perforator. Pathophysiology, PO is obstruction and PR is reflux. Again, spotters that can be asked in the exam are these. So what is your first spotter? This is your telangiectasia. This is your telangiectasia. This is your reticular veins. Now the criteria is simple. This is your reticular veins, right? The criteria is simple. Telangiectasia less than 1 millimeters in diameter. Reticular veins is between 1 to 3 millimeters in diameter, right? Now this is your varicose vein. This is your varicose vein. This happens to be your pigmentation. This is your lipodermatosclerosis. This happens to be your lipodermatosclerosis. You can see nicely the limb is present and sudden narrowing is noticed, and this is what we call it as the inverted. This is what we call it as the inverted champagne bottle appearance. This is your inverted champagne bottle appearance. This is also referred to as the woody limb. Also referred to as the woody limb. Inverted champagne and bottle appearance are also referred to as the woody limb. Okay. Now this is your venous ulcer. Now how do you know that it is a venous ulcer? Number one, look at its area of presentation, and this is what we call it as the gaiters area. So number one, it is present on the gaiters area. Number two, it is present around medial malleus. Now when you look at this, now the first thing you will see presence of sloping edge. Then you will see it's a shallow ulcer and presence of pale, scanty, unhealthy granulation tissue. It is your pale, scanty, unhealthy granulation tissue. Pale, scanty, unhealthy granulation tissue, right? So these are the components of your venous ulcer. Okay? So all these images are important again from the exam perspective, very, very important. Yeah, very, very important. Okay? So that was your question number 16. Moving to question number 17. Now, I have an alcoholic patient, severe abdominal pain, pancreatitis was suspected, CT scan revealed echoic lesion with fluid collected near the body of the pancreas. Which of the following enzymes is most likely to be elevated? Now, it is a classical presentation of a patient having an pancreatitis with fluid collection with an echoic component. It is nothing but pseudocyst of the pancreas. In the pseudocyst of the pancreas, what is elevated? It is your serum amylase and serum lipase. Remember, CEA is elevated in mucinous cyst adenoma of the pancreas. It is elevated in the mucinous cyst adenoma of pancreas. And another one is your intraductal papillary mucinous neoplasm. These are the two contexts where you have in pancreatic component, you'll say CA is going to be elevated, right? So it's only serum lipase that is going to be elevated. GGT is a marker of the bile duct, which tells you either there is a bile duct obstruction or alcoholic destruction. Serum bilirubin will only be elevated if the bile duct is getting compressed. Usually your pseudocyst of the pancreas do not. Okay? So when you talk about the pseudocyst of the pancreas, remember, pseudocyst of pancreas, it takes a minimum of 4 to 6 weeks after the episode of pancreatitis. It is formed after 4 to 6 weeks of pancreatitis. Now, the most common site is going to be lesser sac. But if I change the question to the most common site in the pancreas, then the answer is body of pancreas. It is the body of pancreas, right? Usually it resolves within 6 weeks. After 6 weeks, 4 to 6 weeks is the component, and it starts resolving. If it persists or grows from there onwards, then you have to go with surgery. And the surgery of choice is either cystogastrostomy or a cystojejnostomy has to be performed. Okay? So this is your question number 18. What do we have? I have a 25-year-old patient, abdominal pain, fever for 3 days duration. Chest X-ray in erect position is given below. What is your most likely diagnosis? You cannot miss this. You can see this is the right-sided diaphragm. This is your right diaphragm. This happens to be your liver shadow. This happens to be the liver shadow. So this is the liver shadow. This happens to be the right diaphragm. And in between these two, you have free gas under right hemidiaphragm. This is your free gas. So presence of free gas under right hemidiaphragm gives you a conclusive diagnosis of hollow viscous perforation. And whenever you have a patient with hollow viscous perforation, the management is going to be exploratory laparotomy. Now, if you found that it is a perforated duodenal ulcer, if it is because of a perforated duodenal ulcer, then the management is your Graham's omental patch. It is going to be your Graham's omental patch. Okay? So in that context, what should be done? Diagnosis is not volvulus. It can be a hollow viscous perforation, not an abscess, not an empyema thoracis. So answer here is going to be B for Bombay. It is classical for hollow viscous perforation. A good question is, what is the immediate management? Now, what is the most likely diagnosis? There are two questions. What is the first line management and what is a definitive management? Now, because hollow viscous perforation patients will present to you with Hemodynamic instability. So here start the patient. So 2 large IV cannula. Start the patient on 2 large IV cannula with IV fluids. Definitive is exploratory. It is an exploratory laparotomy. A definitive would be an exploratory laparotomy. Okay. So first line would be to resuscitate the patient and then take the patient for fluid management. Okay. Or then take the patient for definitive surgical management. Clear? So that's a question number 18. Now, when you look at this, the other component that you have, this is an image of, anybody who wants to identify, this is the empyema thoracis. Now you can see nice empyema, right? Put an ICD, would be done. Now here you see this is an image of gastric volvulus. Now when you talk about gastric volvulus, you have something called as, you can see the contrast is not moving any further from here. There is a contrast stoppage, right? What is a Bouchard's triad? Now in a Bouchard's triad, patient will have retching without vomiting. There will be retching without vomiting, presence of colicky abdominal pain, and inability to pass nasogastric tube. Inability to pass nasogastric tube. And this is what we call it as, right? This is what we call it as the Bouchard's triad. Somebody is saying it is the Ellis curve. Again, not a very classical component, but okay, fine. So Bouchard's triad is your exam question. Remember this. That's your gastric volvulus. I hope everybody knows there are two. You have the atlantoaxial and the organoaxial, the two forms of gastric volvulus. Again, in the regular lecture, you'll be able to see those as well. Okay. So that's your question number 18. Moving to question number 19. So what do we have in the question number 19? I have a 6-year-old boy. History of recurrent UTI. Imaging was done, shown below. What is this? Now I can see a dilated ureter. That is only possible if the urine is refluxing back and it is going all the way to the pelvic calcium system and getting blunted and dilated. This is a case of VUR. That is your vesico-ureteric reflux. This is what we call as VUR, that is vesico-ureteric reflux, right? So when you talk about VUR, let's talk about the grades of VUR. When you talk about the grades of vesico-ureteric reflux, now the grades is done, or grading is done on the basis of two components, right? So I'm going to talk about the grade. We'll talk about the extent of reflux. The extent of reflux and the ureter status. Right. Now, when talk about the grade 1 VUR, the reflux is only limited to ureter and the ureter status is normal. In grade 2, the reflux is all the way to the pelvic calcium system, but here the ureters are again normal. Right. So we say the ureters are dilated, but they are normal. Grade 3, the reflux is all the way to pelvic calcium system. Here the ureters become distended. Grade 4, the reflux is all the way to the pelvic calcium system. Now here they become blunted. Okay. Grade 5, reflux is pelvic calcium system and they become tortuous. Right. So what is the difference between dilated and distended? Dilated mein kya hai? Yeah, MCU and cystography. But MCU is maturating cystourethrogram, where you are also evaluating the urethra as well. Cystography is where you are only evaluating the bladder. Right. Fine. Coming back to our component. What is the difference between dilated and distended? Dilated में क्या है कि जब pressure exert होता है तो urethra it becomes bigger in size. The minute you relieve of the pressure, it regains or recoils back to its normal size. Distended में it remains dilated, it cannot recoil back. Blunted में क्या है? It loses its shape also. Tortuosity में क्या है? It becomes elongated also. ठीक है? Now, when we talk about इसी में अगर आप management add कर लोगे ना, we say grade 1 to grade 4, they are called as low grade. So here the objective is to keep the urine sterile. Keep the urine sterile, it resolves. If it is grade 5 or bilateral grade 4 or a bilateral grade 4, for these patients you will go with surgery. Now, when you talk about the surgery that you have, the surgery that you have is uretrovasicoplasty, uretrovasicoplasty or sting, that is subureteric transurethral injection of Teflon glue. That is a sting. Subureteric transurethral injection of Teflon glue. Okay. So this is about the various grades and the management of VUR. Okay. So answer here is vesico-ureteric reflux. It is not a diverticula, not a hernia, not a vesico-colic fistula. Okay. So question number 20. I have a 45-year-old female underwent thyroidectomy. 3 days after surgery, she developed perioral numbness. Which are the following investigations? So post-operative perioral numbness indicates hypocalcemia. It indicates hypocalcemia, right? Now, post-operative hypocalcemia is most commonly seen between POD2 to POD5, right? So here it says on the 3rd day, it sits right across there. Now, the post-operative hypocalcemia can be due to an accidental damage. It can be due to an accidental damage of parathyroid gland. Okay? Now, if you want to evaluate these two, so what will you do? I'm not looking for T3, T4 or the TSH or the radioactive. I need the calcium level, the phosphate and the parathyroid hormone level. So answer here is going to be D, because post-operative hypocalcemia will present to you with perioral tingling and numbness, right? Now, if you say, remember the normal level of calcium that you have is going to be 9 to 11 milligram percent. It is going to be 9 to 11 milligram percent. If it is less than 9, it is what we call it as hypocalcemia. Now, symptomatic hypocalcemia. For symptomatic hypocalcemia, it is, some textbook says less than 7.5 or less than 7 milligram percent. Okay. Now, the earliest symptom, the first symptom to arise is going to be your perioral tingling sensation. It is your perioral tingling sensation or numbness. The second that you will see is presence of the Chvostek sign. A Chvostek sign is the facial grimace that you have. Then you have carpopedal spasm. The carpopedal spasm is seen when you inflate the hand with a BP cuff, and there indrawing of thumb, clubbing of fingers and wrist drop is noticed. And after the carpopedal spasm, if it is severe hypocalcemia, it is going to be tetany. Calcium gluconate is what you have to start, right? So answer here is going to be D for Delhi. Okay. So let's take a short break here for 5 to 10 minutes. Then we'll resume back with the rest of the questions. Okay. Take a short break. Alright guys, back on. ठीक है, चलो, let's continue. Okay, let's kick off to the next question. We have question number 21. This is a very straightforward question. You need to get this straight, so we'll try to understand. A patient presented with blunt trauma to the abdomen. On evaluating, liver injury was noticed, primary repair was done, coagulation function was monitored intraoperatively using the method shown. What is this method? This method is what we call it as TEG, that is your thromboelastography. It is a thromboelastography. Plethysmography is basically for your respiration. Sonography is your ultrasound. Elastography is to check for the elasticity. So it is your thromboelastography, that is TEG. Now, how do you know? If you have a bell curve, which is here, this is normal, right? Now, if you have a long stem and a bell at the end, then that means there's an anti-clotting factor or anticoagulation factor deficiency. If the bell is becoming narrower, if it is becoming thinner, then it is a platelet inhibitory problem. And if it is becoming like a pear shaped, which is getting narrowed here, it is hyperfibrinolysis. And if it does not, if it widens up, it is a hypercoagulable state. Okay. TEG is important. Interpretation of TEG is also important. On a quick succession, this is the graph to be remembered. Now, question number 22. What do you have? Now, in question number 22, a 59-year-old lady have a progressive painless lump in the breast. What is the cause of the following skin change? बच्चों, ये तो देख देख के परेशान हो यार, कितनी बार पूछेंगे सेम सवाल. ये है आपका पियोदे ऑरेंज. This is your Piode orange. Now, this Piode orange is your orange peel like skin. Now, why does the Piode orange occurs? It is because of obliteration of subcutaneous lymphatics. It is due to obliteration. This is because of obliteration of subcutaneous lymphatics, right? An obliteration of subcutaneous lymphatics. Now, if it is see, this can be seen in two conditions. Number one, it can be seen in acute mastitis. It can be seen in acute mastitis. It is also seen in breast cancer. Now, if it is associated with breast cancer, then the staging will become T4B. The staging will become okay. The staging is what we call it as T4B, right? Chalo. Clear? So, why do we have this? Infiltration of subdermal lymphatics is the most obvious answer here, not the lactosiferous duct. If there is involvement of Cooper's ligament, it will result in dimpling of skin. It will result in dimpling of skin. Does dimpling of skin change the stage? Remember, the dimpling of the skin does not change the stage of the disease, but the Piode orange definitely changes the stage of the disease, right? Now, the spread of the tumor to the anterior chest wall, again, no. Remember, when you talk about the chest wall, what is formed? Chest wall is made up of ribs. It is made up of the intercostal muscles and the serratus anterior group of muscle. Serratus anterior group of muscle. ठीक है? चलो. So answer here is going to be A for Ahmedabad. Infiltration of subcutaneous subdermal lymphatics. ठीक है? If I say what are these changes that you can see in breast, quick important components in breast cancer. Remember, the most common site is going to be your upper outer quadrant. The reason why it is the most common site, because maximum concentration of TDLU is present. TDLU is the terminal ductal lobular unit. Okay. Now, the most common type is going to be your invasive ductal carcinoma. It is an invasive ductal carcinoma. Worst prognosis is your inflammatory breast cancer. It is your inflammatory breast cancer. That's a worst prognosis. Now, if we say in lobular carcinoma, if you look at the HP finding, remember it is the Indian file pattern. It is the Indian file pattern. The chemo regime that you need to know, it is your CAF regime. That is C is your cyclophosphamide. A happens to be your adriamycin. And F is your 5-fluorouracil. Okay. There are a lot of other important points as well, but this is the basic that you need to remember for the quick succession. Right. Before we move any further, the whole component here is of questions around 70. I'm currently at question number 22. I'll not take much of your time. So what I'll do is I'll do until 25 questions today, and then we'll have another session, because I don't want to lower the energy or the information or the amount of the topics that we can cover. Right. So we'll keep it precisely to that component only. Okay. Now, this we have already discussed. A child had a history of stab injury, anterior abdominal wall. The image is shown below. You can see something is extravasating. The child is hemodynamically stable. What is the next course of treatment? Now, if you go back to our component here, you can see this is the lacerated wound that you can see, and in the lacerated wound, this is the subcutaneous fat that is exposed. I do not see any bowel though, right? I cannot see any bowel. This is the skin that we're talking about. This is the muscle that I'm saying. This is the, see, when you look at this component, this upper part is your subcutaneous fat. This looks like mesenteric fat or the omental fat. It could be anything. So it is not very clear, so I'm not going to comment much on that. Okay. Now, I'm not going to observe, not fluids. He's talking about what will be the next step. Now, in the next step, fluids can be an option. Wait and watch is not. Observation and wait and watch is same, so it is a dummy option. So you have to decide between emergency laparotomy or IV fluids. So here the patient has a stab injury. Image is shown, the hemodynamically stable status, right? Now, if the patient is hemodynamically stable, I don't look in further context here. But what will be the next course of treatment? Always resuscitate and then do laparotomy. Okay? Always resuscitate and then do laparotomy. In what condition do you do a BRCA chain testing? Okay, I have a question. I would like to address that. कहाँ पे है BRCA के लिए? ठीक है. Okay. Now, there's something called as the HBOC syndrome. That is your hereditary breast ovarian cancer syndrome, right? Now, this hereditary breast ovarian cancer syndrome का जो concept है ना, you need to understand in a very simple format. Now, if I have a patient diagnosed with breast cancer, if a patient is diagnosed with breast cancer and you want to know whether anybody else in the family is affected or not, right? So, this patient who is diagnosed with breast cancer, I am going to screen all first degree relatives for BRCA gene mutation. So the first criteria itself is a family member who is having a breast cancer. In order to look for others, why resuscitate? Beta, fluids ke bina you can't go further. No. See, right now the patient is stable. What if he suddenly starts bleeding? Kya karoge? Nitya, that's the question. No. Yes. Why not do directly laparotomy? For even to perform laparotomy, I have to take an IV access ना बेटा. Next step पूछ रहा है. ठीक है, तो रिससिटेशन का मतलब है कि अभी स्टेबल है, इसका ये मतलब नहीं है कि अगले 5 मिनट भी स्टेबल रहेगा. तो अगर जब तब, अब ऐसा तो नहीं है कि जब अनस्टेबल होगा तभी मैं फ्लूइड डालूंगी. इट इज नॉट द कॉन्सेप्ट. नो. सो प्रॉब्लम, सी, इट्स ऑलवेज प्रिडिक्ट, एनालाइज एंड रिएक्ट. तो मुझे पता है कि आगे चल के अगर ये सडनली ब्लीड करने लगा और पेशेंट अनस्टेबल हो गया, तब लाइन, क्योंकि तब तो लाइंस कोलैप्स होने लगेंगी. इट्स बेटर स्टेबल है तभी लगा लो. डजंट इट मेक सेंस? है ना. चलो. So, screen all the first degree relatives with BRCA gene mutation. Find a patient. Let's say anybody is having a BRCA mutation positive. If the patient is having a BRCA gene mutation positive, then I would see the status. That is the family status. Now, rather than saying family status, I will look at the age of presentation, or let's family only. We'll take family status. We'll say family status is complete, or whether the family status is incomplete. Now, if the family status is complete, I will ask the patient for risk reduction surgery. Now, for risk reduction, you can go advise the patient for bilateral mastectomy with bilateral salpingo-oophorectomy. Now, if the patient has an incomplete family status, I will see the age of presentation. If the family status is incomplete, then I will see the age of presentation, more than 25 years or less than 25 years. If it is more than 25 years, then I would suggest for annual MRI as screening. Less than 25, do nothing. More than 25, you tell the patient to get married as early as possible, have kids as early as possible and come back, right? Beta, here I don't feel it is like bowel. It could be a little bit of mesenteric or the omental fat, but yeah, intra-abdominal content is spilling. Okay. As we have discussed it before, I have the algorithm for you, and that's why specifically we have this question also. You see, if it is an anterior abdominal wall that is being punctured, and then you see that if there is any component that is exploring, let's CT abdomen pelvis, anterior abdomen, get a CT done, and then on the CT you see whether local wound exploration, diagnostic laparoscopy or exploratory laparotomy, negative imaging, then you'll go with serial diagnostic laparoscopy that is there. Okay. Now, here you say shock, peritonitis, evisceration is the intra-abdominal content spilling out, hemodynamic instability free air, directly go with exploratory laparotomy. Okay. So, if IV fluids were not there, then I would say it is exploratory laparotomy, right? Okay, Adya, bye, good night, go sleep. I think you had enough surgery for today, right? See you when you pick surgery as your profession. Bye, Adya, good night. Okay, that's somebody, like my daughter is messaging, so I had to say good night. Otherwise, it's gonna be a bad night for me. ठीक है, चलो. He's asking the next course of treatment, IV fluids. If they say what is the next the ideal management, that is going to be exploratory laparotomy. Go to question number 24. Which of the following is most likely to be seen due to rupture of saccular aneurysm? Now, when you talk about aneurysm, see, you look at the options, all of them are intracranial, right? So here we are talking about rupture of Berry's aneurysm. Now, Berry's aneurysm is going to arise from circle of Willis. It is going to arise from the circle of Willis. And remember, circle of Willis is present in the subarachnoid space. So it will have subarachnoid hemorrhage. So Berry's aneurysm, when it ruptures, it will rupture into subarachnoid space. Hence, it is going to be your subarachnoid hemorrhage. So it is not subdural. It is your subarachnoid, not intracerebral or hydrocephalus. Answer is B for Bombay, right? So such questions are very common sense use questions, right? So most common site for aneurysm overall in the body. Most common site for aneurysm. The answer is going to be the most common site for aneurysm. It is going to be the circle of Willis. If I say the most common site for extracranial, the most common site for extracranial aneurysm, here the answer is going to be infrarenal abdominal aorta. Right? It's an infrarenal abdominal aorta. Okay? Chalo. So the last question for today, it is going to be question number 25. I have a patient with sudden onset of right leg pain. Investigation was done and the image obtained is shown below. What is the investigation? You can see the wave pattern, you see the ultrasound above. So here there is ultrasound image, there is a wave pattern, it's a Doppler. You can see a triphase is there, nothing beats that. It is, yeah, very good, triphasic, beautiful answer. So answer is going to be, this is nothing but what? Is it not? It's not a DSA, it is a ultrasound with Doppler is correct, not MR, not plethysmography. So B for Bombay. When you look at this, this is your DSA, that's your digital subtraction angiography. This is your MR angio, as you can see with the background of, you know, the vessels as well as the brain is here, and this is your plethysmo. Okay. So these are the images, very pretty straightforward. So in that question, right? Again, the leftover session we will plan. I don't know if it is tomorrow because tomorrow some other session is planned. I think on Saturday or Sunday. That sounds good. Okay. So we took, see, the objective of taking this TND is to get you oriented to all the latest exam questions and the topics. So I'm taking the own sweet time to explain you so that, you know, whenever you want to revise, you can come back and revise that question and go. Okay. This video is going to stay forever. We'll send you the PDF also, so don't worry about it. Meanwhile, practice that slot wala question, which is very, very important. I want you to stay in that focused line because exam is not very far. Again, the change in pattern should not affect your preparation. You have to stay focused. Whatever, you know, whoever is giving you any form of input, just shut yourself, listen to one guy you trust to, and just follow. Okay. So with that, good night. I hope the session was productive and fruitful. We'll continue the same in the next component, right? Thank you guys. Good night. Bye. Take care. Okay, guys. So we'll resume back on Saturday probably. There'll be a 2.5 hour session, and we'll continue the same. Okay. If you have any questions, feel free to send the questions under this link. Also, you can send it on the Telegram or the Instagram. I'll be addressing that as well. Okay. Thank you, guys. Thank you. Thank you. Right. I see your message, Adya. I love you too. Adya, I love you. Chalo. Okay. Take care, guys. Thank you. Bye. Good night. Good night. Catch you up.
क्लास करनी है